Welcome everybody to our ECHILD seminar series. For those of you who I've not met, I'm Katie Herron. I'm a Professor of Statistics and Health Data Science at the UCL Institute of Child Health, and along with our team, many of whom are here, lead the ECHILD data resource, which you've probably all heard about because you're at an ECHILD seminar series. So today we're going to be talking about stress and mental health presentations in secondary school-age young people. We've got two speakers, Ruth Blackburn and Kate Lewis from our team at ICH, who are going to be sharing some work of theirs and our colleagues. And I'll let them explain that in more detail because they've got a lot of material to show you. But just to say that this is one of our regular seminar series events, and you can find previous ones on the website along with recordings. So the last one that we did was an overview of the HOPE study, which was looking at special educational needs in children and health and educational outcomes associated with that. So they're all on the events page on the eChild website, and you can find those previous recordings there. So I'm going to hand over to Ruth and Kate, who I think will be talking for about 40 minutes.
Yeah, it should be around about that.
Yep, and then we should have a good 15 minutes at the end for questions. So feel free to put your questions in the chat as you think of them, and then at the end we'll have a nice discussion. Okay, over to you, Ruth.
Okay, thanks, Casey. I will just share my slides. So does that look right?
Yeah.
Excellent. Okay, so, okay. Just to give a quick overview based on what Katie's just said, we've split today's seminar into two parts. So the first focuses on stress-related presentations, including what we mean by these and what we can learn about them from administrative data. And then we present the methods and results from two sets of studies, one which is focused on schools and the other which is focused on racial ethnic inequalities, and a quick summary of these. So I'll be presenting the information on part one. So I'm Ruth Blackburn, and then Kate Lewis is going to present on part two. So Kate, is there anything you just want to say about part two?
Yeah, so for part study, so it's sort of new results on disparities in adolescent mental health related NHS presentations in England. Thanks, Ruth.
Okay, so what do we mean by stress-related presentations? Oh, sorry, skipped a slide. So at the heart of this work is the idea that mental health difficulties often look different in young people compared to adults. And this partly reflects the skills that adults have built in terms of identifying and expressing feelings of sadness or worry. Whereas young people may more often experience these same emotions as physical, emotional, and behavioural manifestations of stress and distress. And I think we will all recognise the things on this list, but they include things like irritability, disruptive behaviours, school refusal, withdrawal, difficulty sleeping, poor concentration, and non-specific physical complaints such as stomach aches and headaches. And we know from the literature and from all kinds of other studies that there's a lot of variation in what this looks like by age and also by sex. So it's important to note that these stress presentations will often resolve quickly and without the need for additional support when the underlying concern is resolved. However, what we focus on in the first part of this talk is the prolonged, recurrent, or more severe presentations where there may be an indication for mental health support. And young people who are experiencing these escalated and more severe levels of distress can often present in acute care settings, so particularly the emergency department. So to give an example of the kinds of presentations which we're interested in and which motivate this study, but which we're not always able to directly measure, I'm going to give a quick example, and then later on in the talk I'll return to this to show what kinds of information can be captured through the ECHILD database. So when Donna, who's a hypothetical individual, but based on existing case studies, when she starts secondary school, she's a high achieving A student. However, as she progresses through secondary school, she starts experiencing abdominal pain and has problems sleeping because of this. She sees her GP several times, who organises a series of tests and scans, but these are all normal. By year 10 of school, she is finding it increasingly difficult to attend due to abdominal pain and anxiety. And at times it's so bad that she goes to the accident and emergency department because there's nowhere else to go. On several occasions, she's admitted to hospital with these symptoms, but the medical tests are all normal. And by the age of 17, she no longer attends school. So in this case study, the patient and her parents had this understandable and deeply held belief that the very real pain that she experienced had a medical cause. And it's possible that more holistic biopsychosocial approaches to her management, including the validation of her symptoms, were needed for things to improve. So the other focus for this talk is on schools, and we think of schools as both a source of support and also as a potential source of stress for some pupils. So they're theoretically well placed to recognise and respond to early signs of mental illness, but in practice, schools are really significantly under-resourced to do this. However, there's been increased investment in this area, and mental health support teams and other kinds of community-based support are increasingly embedded into schools. And these may help to decrease the pressure on NHS mental health services, including child and adolescent mental health services. However, even if these measures are successful, it's likely that there will still be bottlenecks in the system. And whilst these affect access to care for everyone, some groups disproportionately experience barriers to access. And this is a recurring theme within this talk. So within this talk, I'm showcasing some of the work of my colleague Circa, and all of the studies are referenced at the end of this part of the talk. But her work focuses on racial ethnic inequalities and discrimination. So racial discrimination has been consistently associated with patterns in terms of risk-taking, substance misuse, and anxiety and depression. And perceptions of discrimination have also been linked with somatic symptoms. So in the UK, we know that there are differences in the early identification of and responses to distress across racial ethnic groups, meaning that minoritised young people may be less likely to access appropriate and timely mental health support. So, for example, minoritised young people are less likely to be referred to CAMHS from school or GP sources, and are more likely to be referred through social care and youth justice routes than their white British peers. Black and Asian young people are also more likely to be referred to inpatient services rather than outpatient mental health supports compared to their white British peers. And also, other studies have shown that minoritised groups may face additional barriers, including insufficient language translation services, lack of cultural competence, and distrust in some professional groups. So for all of these reasons, it's therefore important to examine whether there are systematic differences in treatment access rates when young people are experiencing significant distress. Sorry. Okay, so focusing now on the data and the measures of stress and distress that we can look at within administrative data sources, including ECHILD and its component data sets. So I think all of you on the call will be familiar with ECHILD, so I'm not going to go into a lot of detail on the slide, other than to say that the QR code, which is shown here, links through to all of the resources. So these include descriptions of the data set, published code, help guides, and user manuals. So it's a really good place to get started with working out how ECHILD might support your own research use. So the original ECHILD database included two core linked datasets, the National Pupil Database and Hospital Episode Statistics. So these are linked at child level in such a way that we have longitudinal de-identified data currently on 20 million children and young people in England, with the possibility of following them from birth up to the age of 38. So within these core data sets, we can look at information on school and pupil characteristics, including educational attainment at key stage examinations, absences, exclusions, free school meal status, and special educational needs provision, or records indicating that eligibility. There's also a host of other information which I'm not going to focus on so much for this talk. In terms of the hospital episode statistics, these are all data sets which are held by NHS England. The data set that's the main focus of my part of the talk is the admitted patient care data. So this includes admission and discharge dates, ICD-10 codes, which include things like diagnostic and symptom information using these ICD-10 classifications, and also includes information on A&E contacts and linked mortality data. So in the first part of the talk, this admitted patient care data is used, and I'll tell you a bit more about how we identify mental health related presentations within those contacts. In Kate's part of the talk, she's also going to introduce use of the mental health services dataset, so specifically the data available from 2016 onwards, which includes children and young people. So within the extended version of eChild, we do have another dataset, the minimum mental health dataset, which is available at earlier time periods, but that reflects data for adults only and isn't part of the focus of this talk today. So returning to the case study that we looked at earlier, if we map on Donna's story to the eChild data, we'd be able to look at an indication of her educational attainment, for example, using Key Stage 2 examinations. We would be unable to see any information about primary care, so including GP visits, but we would be able to look at her pattern of absence throughout school, and A&E attendances and hospital admissions, and to look at these longitudinally to understand the sort of trajectory that she had through health and education records. However, you can see that there's also a lot of information that we would miss, particularly through the primary care context. So one of the key points, particularly for the first part of the talk, where we focus on hospitalisations data, is that in the context of mental health, we miss a huge amount of the true community burden experienced by young people. So in particular, those who never disclose or never seek help for mental health concerns, and those who come into contact with GP or community health services are not included in this data. We just focus on the extreme tip of the iceberg in terms of hospitalisations. However, as you will see from the data that I'll present, actually these hospitalisations are not extremely rare, and they can still tell us something useful about the pattern and the young people who are most at risk of these hospitalisations. So what we looked at. So we focus on stress-related hospital admissions, and this was defined as emergency admissions to acute NHS hospitals, where the main reason, so the primary reason, was a stress-related code. And we developed coding clusters based on literature review and clinical input. We also looked at emergency admissions where a self-harm code was recorded in any diagnostic position. And so what this gave us was 5 coding clusters. And these reflect somatic and pain-related symptoms. So this is things like unexplained abdominal pain, headache, breathlessness, fainting or fatigue. Self-harm behaviours, and in particular, because these are hospital admissions, certain presentations like self-poisoning are significantly overrepresented because they're more likely to result in an admission. Internalising and externalising clusters, so this includes anxiety, depression, and eating disorders within the internalising cluster, and things like disruptive behaviour and substance misuse in the externalising group. We also looked at thought disorders, so this includes things like symptoms of psychosis and schizophrenia. But I'd note that some of these diagnoses, particularly schizophrenia, would not normally be made in a child, so they're likely to be reported at low levels. So these emergency admissions were identified through ICD-10 codes which relate to these clusters. So within each admission, up to 20 ICD-10 codes can be recorded, and also multiple procedure codes as well. And we particularly use the procedure codes to apply medical and surgical exclusions to try and remove cases where pain-related or potentially somatic symptoms are likely to have a medical cause. So, for example, where abdominal surgery has been carried out, for example, these individuals would be excluded. However, it's very difficult with these relatively non-specific clusters of codes, particularly for the somatic and pain-related symptoms, to be sure that they have a potential mental health related basis. So you should really consider the relatively low levels of specificity which are quite likely for some of these codes when thinking about the interpretation of the results. So returning then to the inequalities work, we examined group differences based on the variable ethnicity. So this is a flawed substitute for the lived experience of individuals from minoritised ethnic groups living in a white British majority country. And we note here that ethnicity is not a risk factor, but differential treatment based on race or ethnicity is. And also that in the UK, this variable ethnicity includes both race-based and ethnicity-based identifiers, which mix someone's actual or perceived physical appearance and ancestry with characteristics such as language, cultural factors, religion, and geographic territory. So in terms of the groupings, the categories that we used had to reflect the underlying data collected, and this is based on the Office for National Statistics census categories, and they don't reflect our opinion. So we used the finest categories possible. However, due to small numbers in some groups, it was necessary to combine some of these ethnicity variables. So our groupings reflect the 12 groups shown in the middle here. And in some cases, we also refer to broader groupings, but this is where the findings seem generalisable within the groupings that are mapped from the broad groupings to our groupings. So what we found. So firstly, thinking about the schools work, in this study we were asking, do schools influence mental health? And we focused on two questions. The first was whether rates of stress-related hospital admissions in secondary school aged young people are higher in term times than holiday times or not. And secondly, who, thinking about both school and pupil characteristics, seem to have the greatest risk of these stress-related admissions. So on this slide, we have the weekly rate of stress-related presentations per 100,000 adolescents and the age at which these admissions occurred. And what these show is that around 31% of all emergency hospital admissions for people of secondary school ages were stress related. So actually this category of codes that I outlined earlier is accounting for almost a third of all hospital admissions in young people. So that's a very significant burden. In terms of child level risk, over the course of secondary school ages, 8% of all girls and 4% of all boys were admitted at some point with a stress-related presentation, which is more common than you might think. We also found that for all ages, for both girls and boys, term time rates were significantly higher than holiday time periods, with the exception of 17-year-old boys, where there was no statistically significant difference between these two rates. For the girls, but not the boys, there was a very sharp peak around the age of 14 to 15 in terms of rates for girls. And this is something that we've also seen in a variety of other projects, including some of the work that Kate's going to present. So what this graph shows is that we did find much higher rates of stress presentations, particularly for girls, during term time than holiday periods. But we note here that this may be a reflection of school stress, and or it may also be a reflection of schools influencing health-seeking behaviour among young people. And in particular, this may be the case for self-harm. So when we think about an individual school, so an average secondary school within this study included about 750 pupils out of a total study population of just about 2.9 million, looking at a single academic year, which was the last year before the pandemic. And what we found was that around 1.3% of all pupils were affected, but when you consider this at school level, almost all schools, so 96%, included at least one pupil with a stress-related admission. And that in an average size secondary school of 750 pupils, around 11 pupils per school were admitted in a single academic year. What we also found was that pupil and school characteristics explained most of the variation in differences between schools, and that school level effects accounted for only a relatively small part of this. So this is indicated by an ICC of 1.7%. Looking then at the school and pupil characteristics, which were important, we found that the type of school, so in particular local authority, had higher odds of stress-related admissions, whereas special schools had lower odds of these admissions, were important in terms of indicating which school characteristics were important. And then at pupil level, unsurprisingly, perhaps having a personal history of a stress-related presentation in a previous academic year, so an earlier year, was the most strongly associated factor with subsequent stress-related presentations, but also a variety of other factors, including having a chronic health condition, having been in contact with children's social care, the racial ethnic group, which I will go into more detail, really focusing on in Circa's work, being in older school years, having ever had free school meals, special educational needs provision recorded, persistent absence, that's missing 10% or more of sessions in the previous year, and having a history of having ever been excluded from school. And we highlight here that actually many of these factors are actionable for schools, so in particular how they respond to persistent absence and what their policies are around exclusion, how they work with pupils with SEND provision, for example, are all actionable at some level for schools. So returning then to the inequalities work, so the project aimed to explore whether there are systematic differences based on race and ethnicity in hospital admissions for these stress presentations in school-aged adolescents. And it focused on 4 different areas or indicators of these. So the rates of these admissions, the distribution of repeat admissions, the duration of the admissions, so whether they were longer or shorter, and also the types of presentations. So this slide shows yearly rates of admissions for stress-related presentations. And what you can see is that there's a lot of variation across racial ethnic groups. So across all ages, what we can see is that mixed white black racial ethnic groups and white British young people has among the highest rates of admission. And there are also some nuanced differences by age, with the youngest Pakistani people having amongst the highest admission rates, but with less of an increase at ages 14 and 15, with higher rates amongst the other mixed racial ethnic peers. So conversely then, across all ages, white other, Black African and Indian young people had amongst the lowest admission rates. Moving then on to the repeat admissions, what we can see from this slide is that the white British, mixed white black racial ethnic groups and Pakistani young people had the highest percentage of readmissions. The light blue bars here indicate a single admission, and the darker blue indicates subsequent admissions. So at 2, 3 or 4 and above repeated admissions shown in the darker blue. And then what we also see is that these readmissions were less common in other minoritized groups, so with white other and black other young people being least likely to be admitted. Focusing then on the duration of admissions. So we thought about this in terms of longer admissions, so those aged, those which were more than 3 days, so that's the 2 darkest shades of purple, and compared that then to those which were shorter admissions. So what we found was that young people from Black other, Bangladeshi, Asian other and Black Caribbean groups experienced the highest frequency of these longer admissions, and white British and Indian young people were least likely to experience these longer admissions. Okay, this is a very busy slide, but I'm going to break it down and work clockwise round the slide. So this slide shows the overarching trends in the types of stress presentations. So that's what these presentations look like. So panel A looks at the proportion of stress-related presentations which were psychosomatic. And this is the biggest and the most common group. So what we found was that young people from all Asian groups, as well as Black African and other racial ethnic groupings, were admitted with potentially psychosomatic symptoms more frequently than their white and mixed racial ethnic peers. Looking then at panel B, which focuses on internalising presentations, we saw the opposite trend, with white and mixed racial ethnic groups appearing to be admitted more frequently with internalising presentations than their racially minoritised peers. And this was highest for white other and mixed other racial ethnic young people. In contrast, we found that Pakistani and Black African young people were least likely to be admitted with internalising presentations. So moving down to panel D, so this looks at self-harm, where we saw a similar set of trends with young people from all Asian groups, as well as Black African groups being least likely to be admitted for self-harm, whereas white British and mixed white Black racial ethnic groups were most frequently admitted. Then finally, panel C, so this is focusing on the externalising presentations, where we found that white British, mixed white racial ethnic groups and mixed other racial ethnic groups were admitted most frequently with externalising symptoms, and all Asian groups, as well as Black African young people, were admitted less frequently with externalising symptoms relative to their peers. So just to provide a quick overview of those sets of slides that we've just looked at, because it's a lot of information. The kind of general trends here show that for the white and mixed racial ethnic groups, there were generally lower levels of somatic related presentations, higher internalizing, externalizing, self-harm and multiple diagnoses. For the Asian and Black African groups, we saw higher somatic related presentations, lower internalizing, externalizing and self-harm, and generally lower levels of multiple diagnoses. And then for the Black Caribbean group, less pronounced, we saw kind of generally less pronounced trends in either direction for some of these sets of presentations, so particularly for somatic and also for the multiple diagnoses. But we also found lower internalizing and higher externalizing presentations in general. For the Black, other and other groups, we also saw some of these less pronounced directions in terms of the somatic presentations, but similarly lower internalizing presentations and slightly higher rates of self-harm presentations. So to summarise, in terms of our question of do schools influence adolescent mental health, we saw strong evidence of term time peaks in stress presentations, and almost all schools, so 96%, were affected in a single academic year. And in an average sized school of about 750 pupils, 11 were admitted in a single year with stress-related presentations. We found limited evidence of school effects on stress presentations, and instead these were more strongly influenced by school and pupil characteristics. And we feel that it's likely, therefore, that school responses, so whether they support or punish things like pupil absence and exclusion, are likely to have some influence on pupil stress and may therefore influence these kinds of admissions ultimately. However, these relationships are incredibly complex, and for this reason, mixed method studies and longitudinal approaches are really needed to better understand these relationships. In terms of the inequalities work, the findings indicate inequalities both in terms of rates and differential experiences. So, for example, the length of hospital stay for stress-related presentations based on race and ethnicity. And these differential pathways indicate potential biases in triage, assessment and treatment, which may contribute to these inequalities in admission. So one of the key takeaways from this is that race equity frameworks are needed to reflect cultural adaptations for different groups to help try and reduce some of these inequalities. So to acknowledge all of the people who are involved in this work, so particularly Circa, who has written this paper shown here on the right-hand side, and all of the other co-authors. So thank you, and I will hand over to Kate for her part of the talk, and we'll take questions on both sections at the end.
Thanks, Ruth. I am going to just share my screen. Just share and then swap presenter view. Hopefully that should be all right. Okay, yeah, so I'm going to present on some emerging work, which really expands on the work that Ruth has just been speaking about. So this was work in partnership with the Bradford Institute of Health Research, and it was funded by the Children and Families Policy Research Unit. So expanding on this work, we looked at additional axes of inequity. So one of the main axes that Ruth just spoke about was racial ethnic groups, but we also looked at region of residence in England, gender. There's only 2 categories, unfortunately. This is from the National Pupil Database, the index of multiple deprivation to get an idea of neighbourhood, socioeconomic circumstances, and 3 school meal eligibility, so that indicator of individual level socioeconomic circumstances.
Sorry to interrupt, Kate, you might want to switch your screen because we can't interview. Yeah.
Oh, thank you. Appreciate it. Is that better now? No? Oh, maybe I'll stop and go again then. Thanks. Okay. Let me see. Is that better?
Yes.
Thanks, Katie. So this broadly matches with the core 20+5, and these are the target populations in the national NHS England approach to supporting the reduction of health inequalities at the national and system level. So I just wanted to briefly introduce the framework that guides this work, because I think it's very important, especially when we're talking about something that's just a measure of healthcare utilisation, as so often we use in these studies. So this work was guided by a social determinants approach, whereby the wider context influences the positions occupied by people in society. So that's the social strata that I talk about. And these positions don't operate in isolation, but intersect with one another. This in turn influences a whole host of exposure to social, economic, and environmental stresses, as well as material and psychosocial factors at the individual and neighbourhood level. So even before we get to what are the underlying mental health needs of young people, we've got all these background factors going on. And then on top of this, we've got factors that are intertwined and relate to access. So not only the motivation of abilities to want to access these healthcare services, but also the accessibility of those services themselves. And in red, there's just some points highlighted that come up repeatedly in PPIE work. So that's the background and attitude and perceived judgment of teachers and health professionals. So that affects whether young people want to access services. So again, just to say that we're measuring contacts at several points, but this really is downstream from all these factors. So there's a lot going on behind the scenes. So in this work, we're investigating 3 points of contact with services. So at the bottom, you've got the emergency hospital admissions, which Ruth has just explained. And we do that with and without psychosomatic symptoms. So referrals to mental health services, so that's using the mental health services dataset. And we aim to exclude neurodevelopmental concerns or neurodiversity related difficulties. So any referrals that just relate to those things, we try to exclude using reason for referral and service type codes, but it's likely that we don't capture all of these. And our second point of contact is mental health related emergency department attendances. So that's measured in the ECDS. Secondary school between 2012 and 21. And we adjust just for year of follow-up, and we stratify by age, and in later analyses also by gender to look at intersectionality. However, I don't show these today. I'm just going to show some brief results today. And I'm just going to show the results of the 11 to under 16 group 2 to try and keep the results quite concise. And just to note, we only include the first outcome by each child. So the first referral, ED attendance, or hospital admission. So just to give you more detail on the cohort, because I think especially for people, if you're going to be using ECHILD, these are the sort of nitty gritty that's important to know. It's a bit of a complex cohort structure. So we've got along here, we've got children entering year 7 at these years, and then our outcomes are measured along this axis here. And you can see the hospital admissions are measured for this entirety of time. But the mental health services data set only came into place in 2016, and the ECDS, which has more detail that had been available from the A&E data set beforehand, is just available for these last 2 years. So it's a bit of a complicated structure going on in the background. So this is the flow chart for the study. I just have this to point out a few things. So I just want to point out some potential biases in the data. So firstly, as we've already mentioned, young people have to be enrolled in year 7 of state-funded school to be in this data. So that means that children that are in independent schools, those who have been excluded before this point or are homeschooled won't be in this data set. And the second point is if they're not linked to an NHS health data set, they also won't be in this study because we can't follow them up. And that's about 4.5% of the population. But in all, we do have a population of over 5.6 million children, of which 17.4% have a referral to mental health services within that time. So it's a very high proportion, and a lower proportion for emergency care and admitted patient care, as you would expect. So some results. So here we have the rates per 1,000 person years of referrals to NHS mental health services. So the rates along the bottom here, and that's the year adjusted mean line you can see running through here. So if we take it strata by strata, we can see some clear variation by social strata. So females, as shown in Ruth's work, are far more likely to have referrals than males. There's some quite large regional variation, particularly high rates in the northeast and low in London. We see a clear socioeconomic gradient. And when we measure at the individual level using free school meal eligibility, we see a particularly high rate here, so very high referrals compared to those who are not eligible for free school meals. And again, we see a lot of differences between racial ethnic groups. And here we were able to use the full 20 groups because our outcomes are bigger, so we've got bigger numbers. So again, though, we see some similar patterns whereby pupils that broadly fall under the Asian group have particularly low rates, as well as Black African and Chinese. But Black Caribbean have rates nearer to the average. Some groups with particularly high rates include the mixed Black Caribbean white, Irish travellers, and there's the British group there as well, having quite high rates compared to the average. So these were the mental health services. The next chart is the same thing, but it shows the ED attendances. So you can see just from a quick glance that the patterns are really similar actually. So high for females, males, low in London, high in the north, etc. And then again for hospital admissions. So this is mental health related hospital admissions, and this doesn't include the psychosomatic presentations. And again, we see very similar rates. I don't have the slide here to show, but when you add in the psychosomatic presentations, there is some clear changes, and particularly for the Pakistani group, where their rates are almost at the mean. So very similar to the work by Circa shown earlier. So really showing that the outcome matters and how you're measuring it. Just to put all 3 service contacts together, this is now the same information, but on a relative chart. So this is the incident rate ratio. So anything above the line is more than the average, and anything below is less. And what you can see is for a lot of these groups, there is actually strikingly similar patterns relatively across these services. So particularly for socioeconomic deprivation, and for a lot of the racial ethnic groups, you can see really similar clusterings across the contacts. Where there seems to be a big difference is with gender. So females relatively have far higher hospital admissions and ED attendances compared to the rates of referrals. So just to summarise, there's clear variation by social strata, but actually strikingly similar patterns across contact points for most groups. This cautiously suggests that relative usage across services is consistent. There's not some groups, for the most part, using one type of service more than the other. However, I think it's really important to say that particularly Circa's work that Ruth's just shown shows the importance of the chosen outcome. So are you including psychosomatic symptoms? You know, we've not looked at repeat admissions or the duration of admissions, or even referral pathways, which we know are very important source of bias. The big outlier in this is probably gender. And this is particularly with the greater relative rates of hospital contacts. And this may be due to the process of gender socialization throughout the sort of underlying reasons for need, and also the barriers to access. One specific point is that it could be due to gender-specific methods of self-harm. So young females are more likely to be admitted to go into ED with poisoning, which is more likely to need admission. So there's a lot going on in the background, and we're still working out what all these results mean. The third point I just wanted to raise is the regional differences. So you see these consistently higher rates for the north and lower for London. And there's, again, lots of underlying factors that likely contribute to this, including the population that lives in these areas, but also thresholds and service delivery. So we know that people who present to the emergency department in London are far less likely to be admitted into hospital than in other parts of the countries. So next step, so the manuscripts in preparation for this work, and as I mentioned earlier, this work is in complement with colleagues at the Bradford Institute of Health Research, and they're using the Born in Bradford to look at a similar question. So they've got information on a more localized area, but they have a lot more detailed information, including some of those underlying measures of need. So being able to adjust or control for those, meaning they can look at access at the point of trying to access the services rather than the underlying need. So that bridges some of that important inequities gap that we're missing here. And we've got some future work in the planning stages, including perhaps we're going to look at crises contacts or different types of intersections, so ethnicity and socioeconomic circumstances. And myself and Ruth are part of the Population Mental Health Partnership. And for this work, we're investigating local level variation in the utilisation of mental health services. And there's lots of thank yous and things on this page, but I guess the main one is to thank the children and young people whose data, that patient data we use as part of our work. Thank you.
Thank you, Kate, and thank you, Ruth. That was fascinating. So much in there to discuss. So let's open up the floor for questions. There have been some in the question and answer box. I don't know if participants can actually put their hand up, but if you can, you can. If not, put your question in the Q&A box. So one of the questions from a couple of the audience members were about separating out the neurodiverse and neurodevelopmental admissions and why you did that.
Yeah, great question. I'm glad to get more time to talk about it, actually. So the reason why we tried to exclude, so it was just for the referrals to mental health services. Basically, in the mental health services data set, you not only have contacts with mental health services, but also learning disability and autism services. So obviously, we know that children who are neurodiverse are more likely to also have mental health conditions. But what we were trying to do is not have the referrals that solely relate to the neurodevelopmental concerns. So things like learning disability services, we were not including that in our measure because we're trying to look at mental health service use. However, if a child is flagged as having one of these concerns, we won't exclude them if they've also got referrals into actual mental health services, if that makes sense. So, and it's not perfect because we're just trying to figure out ways of working the best way we can with the mental health services. So as far as we know, diagnoses aren't particularly well recorded. So we're just using sort of service type referred to as sort of flags for these things. So that's why, yeah.
Yeah, that makes sense. Okay, thank you. Question from Gareth. Ethnic minorities are less likely to have inpatient admissions in the introduction, but more likely in the school results. Is that something that you saw, that difference?
So in the school results, actually, we found differences across racial ethnic groups, but actually the very crude groupings that we had, the minoritized groups were actually less likely to have admissions, so in line with the introduction. So what we were finding across the different data sets and measures we use was actually fairly consistent for, well, fairly consistent for some minoritized groups, but how you group the data is really important, and that's definitely demonstrated very nicely by Circa's work, which then inspired the groupings that were used for the work that Kate's just presented as well.
Thanks, Ruth. A question from Eleazar. Have you, Kate, looked at your results by year to look at changes in data quality over time, but also any disruption due to COVID?
Yeah, very good question. So when I initially started this work, just to do some quality checks, I did look at rates over time. I think it's a little bit difficult with the study design I used to get. I wouldn't be able to use this study design to show rates over time. I think you'd have to have a different one because of the way it's set up. But yeah, you do see changes around 2020, 21 that likely refer to COVID, and I do think that could be looked into further. The ECDS, I suppose, we're only using those 2 years, so we don't really have anything to compare it to, unless we were going to use the older A&E data. So in answer, yes, we know it does affect the data, and hence why we looked at it in terms of like as a research question now.
Thanks, Kate. Yeah, we do know the ECDS is completely different in structure from the older A&E data. So even if we were trying to compare that, I think that would be difficult, although we think it's more well completed. Okay, another question from Lorenzo for Ruth. Do your findings indicate that there is variation across schools in the prevalence of stress-related presentations, and is this explained by student characteristics?
Yeah, so the data that I showed was just for a single year of data, so for 2018-19. So what I haven't done is look at the stability in variation between schools over time. It was just for a single year. So, take what I'm going to say with a pinch of salt. But what the results that I presented show is that in a kind of multi-level model where you have pupils nested in schools, the level of variation in the odds of admission with a stress-related presentation is very largely explained by school and pupil level characteristics rather than the unexplained variation which exists at the level of the school, which was only about 1.7% of the total variation. So in essence, not a lot of variation explained by the school, but much more of it explained by the composition of the school in terms of the pupils within it.
Can I ask a follow-up question quickly, just out of interest? Were you surprised by that? It was a very low ICC. Were you expecting it to be higher?
It's very similar actually to other studies which have taken place in Scandinavia, for example. And actually there seems to be something about looking at school level or variation between schools at anything population based, where you seem to end up with a roughly kind of like 1.5 to 4% ICC. So I don't know whether that tells you something about the natural variation you get in groups of pupils between schools, or and the relationship between those characteristics and health presentations. But in the literature review that I did to support the work, it seemed to be quite in keeping with other studies where they reported those measures.
Thanks.
There's also a question about how much of what you've presented today has been published. I don't know if you want to summarise which bits have and which bits haven't yet.
Yeah, shall I start? The work on the stress-related presentations across minoritised groups, that has been published, and that I showed the reference for that towards the end of my talk, and so some of the stress-related presentation term versus holiday time period presentations, that work has also been published, but the information on variation between schools has not been yet, although it's been presented at lots of different conferences. And the CIPRI work that Kate presented, sorry to say for you, but in for you, Kate, but that hasn't yet been published.
Vincent, you popped up. Would you like to ask a question?
Yeah, maybe, if that's all right. Is there any plan to look at perhaps mortality outcomes?
Not within the planned work for this. Yeah, it's a good question. We are looking at some further kind of partnerships and also actually some validation of the extent to which it's possible to use the mortality data to look at some of these outcomes, because there have been some anecdotal concerns that there may be under recording of deaths, partly I think due to the delay in terms of death certification where the coroner has to be involved. But yeah, so there's interest in doing work in that space, but it's not going to happen immediately.
Gotcha. Yeah, because my understanding is that there's a peak when, you know, kids start to go to university. I was wondering if that happens, you know, around the O-level time or A-level time as well.
I guess originally for the CIPRI work, we had it down as something to look at, but we thought with the amount we're looking at, and suicide is such a sensitive and important topic to get right, that it wouldn't be right to just, you know, have it with all these other outcomes, that maybe like some really specific work with a lot of PPIE would be like necessary. So I think that's where we got to on that one.
Okay, I have got some questions too, but I think we should wrap up and let everyone have 2 minutes. So thank you very much. Thank you very much to Kate and Ruth and Circa in particular, but also thank you to you as an audience. Thanks for the questions and the engagement, and we hope to see you again soon. Bye.
Thanks, Katie. Bye.